ulnar nerve palsy. This is the second common nerve compression after carpal tunnel syndrome. The ulnar nerve can get compressed into the palm, or it can get compressed at the elbow joint. It can get compressed on the palm when the ulnar nerve is winding around the hook of the hamate, or the ulnar nerve is winding around the medial epicondyle. It's on the posterior to the medial epicondyle. It has had several names over the period of time, not that it matters now. Now the nerve can get compressed at multiple sites. This is important because if you don't know this thing, we can make a lot of wrong interpretations. What that means, I'll come to that. The ulnar nerve can get compressed when it is going from anterior to posterior and crossing the medial intermuscular septum. Point 1. It can when there is a facial band between the medial epicondyle and olecranon at the proximal edge. It can get compressed. It can get compressed between this medial wedge. It can get compressed just when it is exiting, or it can get compressed when it is entering and within the flexor carpi ulnaris. Now when you are operating this patient, it is very important you decompress all these 5 sites. If you don't compress, you will have residual symptoms. And then if you do whatever options which I am going to talk, the surgery is likely to not be very rewarding. And therefore, you have to identify, okay, 1, 2, 3, 4, 5. And that means the incision has to be longer. Now what happens if the elbow is flexed? The cross-sectional area of the tunnel diminishes significantly during flexion. So if this is during elbow during extension, suddenly it compresses, and therefore the symptoms are when the patient elbow is flexed, and that is a clinical implication. That means if you want to precipitate the symptoms of the patient, flex the elbow. Why? Because in the flexed position, now the ulnar nerve is going through a longer excursion. Symptoms are in the ulnar nerve distribution, in the medial ulnar 1.5 finger, in majority of patients, not all the patient, because your clinical examination will be important. As disease persists for a longer period, patient can have weakness, patient can have ulnar clawing, patient can have weakness of the adductor pollicis, first dorsal introsus, and clumsiness of movement. It's extremely important, the word clumsiness of movement. Why it is important? Because if the patient has gone to physician, the clumsiness would mean be direct interpreted as writer's cramp. The moment he has a label of writer's cramp, he is never going to get alright. And this is a treatable condition. And therefore, do not accept a ready-made diagnosis. Once patient brings a plethora of papers, keep them aside. You interpret them unbiased, make your own diagnosis. Don't even see the report given by the MRI wala. These reports that patient is carrying often can mislead you and give you a biased possibility of an interpretation, and therefore keep them aside, make your own diagnosis, and then see the papers and see whether you have missed out anything. Signs: there is tenderness on the nerve posterior to the medial epicondyle. The second test, as I said about the anatomy, passive elbow flexion test. You keep the elbow flexed for about half a minute, 1 minute. Now the ulnar nerve is getting compressed, and this will say I am getting tingling in the hand. So you made a second clinical observation that the ulnar nerve is gone. And third thing is tap along the course of the ulnar nerve, and the patient is good, I've got tingling. Differential diagnosis: the nerve can be affected more proximally or distally. More proximally can be a thoracic outlet syndrome. You may probably, not always, probably you have some new bone formation, new bone like the cervical rib, which may be visible, but again, often do not get misled by one thing, a ready-made diagnosis, second by an X-ray, because again the patient can have a double compression. Patient can have thoracic outlet and patient can have ulnar nerve also, and therefore if the Tinel sign and passive elbow flexion test, these are positive, you err on the diagnosis of ulnar nerve compression rather than thoracic outlet compression. There are tests for thoracic outlets compression, Roos test, adjacent test, so you have to carry out these tests also. An abnormal angle at the elbow, that means the ulnar nerve now is going through a abnormal longer excursion and can precipitate symptoms. So these are the patients who have a straight ready-made diagnosis, and therefore treatment is decompression at the outset rather than any conservative management. Investigations: Lot of investigations are available, from X-rays of the wrist, cervical spine, elbow, CT, MRI, angio, but the diagnosis is clinical and it is absolutely unjustifiable. You can do all these tests, but it's not going to lead you anywhere, because as I said, diagnosis is clinical. Differential diagnosis can be medical conditions like diabetes, hypothyroidism, and you may rule out or do a parallel treatment for these situations also. What about electrodiagnostic test? This is not the test which is going to be helpful in majority of situations. Clinical diagnosis is a must, which only is going to clinch the diagnosis. The electrodiagnosis can be false positive, negative, and therefore can be misleading. Repeat electrophysiology, it's not going to help. Non-operative treatment. So prevent the patient from doing elbow flexion. If it's a computer operated, so ask him to keep the keyboard away from the body so the elbow is relatively straighter, and probably that might ease the pain. If he's used to reading like this, ask him to keep the elbow extended. If not working, then ask him to wrap a crepe bandage in a wider 6-8 inches so that elbow is not flexed too acutely, and that can ease the symptoms. If he's cycling bent forward, elbow bent, avoid this thing. I talked to you about that multiple levels of nerve compression. So multiple treatments are available, but if you do incomplete decompression or medial epicondylectomy, the compression can be at other areas, and therefore very important you identify all the places where the nerve can be compressed. So you have to decompress at all these 5 places to have a complete relief of this patient. So we had this patient, medial incision, identified the ulnar nerve, medial epicondyle exposed, and the whole ulnar nerve was, and just can you see the diameter of the nerve here? So the nerve was compressed in this area. You also see the color difference of the nerve. This is a different color, this different color, and this focal area the different color. So unless you do a total decompression, you are likely to miss this thing. Do you appreciate? These are engorged vessels are also very easily available, and color change of this narrow area of the ulnar nerve on the medial side of the elbow. At this point you can stop the surgery. This is called as decompression in situ. The other option, if you want, not that it makes a difference, you can do an anterior transposition. You create a slings of fascia and transpose and anchor the nerve on more proximally. I have done this plenty of time, but now I do more extensive decompression and decompression situ. Just leave it there. The word is extensive decompression of the nerve. There are times when you will see a nerve which has a tumor. Now you don't have to cut the nerve. You can enucleate, split along the fibers, enucleate the fibers, keeping the fibers intact, and take out the tumor within the nerve. So we talked of ulnar nerve compression more proximally. There are situations where the nerve is compressed more distally, and often the situation will be you have a ganglion or a calcinosis or some kind of a tumor which is compressing the nerve when the nerve is in the Guyon's canal. Another patient, pain, localized tumor, ulnar nerve compression, excise, relief. So in summary, look at the patient's gesture. They are telling you the surface anatomy of a nerve. Location can be elbow, can be wrist. Tenderness is the clue. Passive elbow flexion test and tenderness here will clinch the diagnosis.